All right. Thanks to the Dutch Resuscitation Council for the invitation to speak at this virtual conference. I understand that during the conference we had some technical issues, so instead we agreed to do this recorded session, and I hope you will enjoy that as well. My name is Rasmus. I'm a tactical and critical care paramedic and PhD student at Kopenhagen EMS, and I'm doing a PhD on feedback from out-of-hospital cardiac arrest. For the next 20 minutes or so, I'll be talking a bit about real-time feedback in general and some of the challenges we face in manual ventilation in the pre-hospital setting. I'll also present the results from a randomized simulation trial where we investigated real-time ventilation feedback, and I'll talk a bit about the future of real-time feedback in general in EMS. And hopefully this will work. There we go. Before we crack on, we need to talk a bit about the main headlines of real-time feedback. In general, we have two types of feedback. We have real-time feedback and we have post-event feedback, which could also be referred to as a clinical debriefing. Real-time feedback is, as the name implies, a feedback type that is given instantly during an event, and it allows whoever is receiving it to adjust accordingly to the feedback as soon as it is received. Post-event feedback is given after an event, and it allows for a more in-depth analysis and a broader perspective, but any corrections or adjustments that we need to make in our practice is not possible in the actual event, and it will have to wait until a subsequent similar event. Regardless of the type of feedback, the aim is to achieve one of two things: either to confirm a practice or to adjust a practice according to recommendations. So in short, we seek adjustment or confirmation. So let's have a look at real-time feedback in general. When I refer to real-time feedback, this includes the use for both chest compressions and for ventilations. Because real-time feedback is not just real-time feedback, and when we talk about the effect of real-time feedback, the devil might be in the detail. So just to give you guys a broader perspective, I'll briefly go through the elements of real-time feedback. Real-time feedback can be presented as either a visual presentation or as audio. Visual presentation can be either text, graphics, such as figures, symbols, and numbers, and it can use various colors to draw focus to the feedback. Audio, it can be either tones or voices, and the two, visual and audio, can be combined. We have two types of real-time feedback: autonomous or imputed. Autonomous is when feedback is given without any interaction from provider, performance, or patient response. This is seen in most older defibrillators with a metronome and sounds for ventilations like 32 or 10-to-1 algorithm. And it just kind of keeps a steady pace regardless of what performance the provider actually delivers. Imputed is seen when either performance or physiological data is available to the provider. Feedback can be either continuous, or it can be adaptive, or it can be a combination. Continuous is when feedback is given regardless of, there's no break in the feedback. It could be chest compression depth, for example. So my feedback is always shown when I do the compressions, regardless of it being the performance I do is within the guidelines or outside the set of guidelines. Adaptive is when the feedback is only activated when my performance is above or below the guideline recommendations. This is typically seen in metronomes, where I do a performance of 110. I have no metronome. As soon as my performance drops to, for example, 90, the metronome kicks in, and then picks up the pace until I'm within guideline recommendations again. Finally, the two can be combined. A key feature in defining real-time feedback is how the feedback data is generated. This can be either performance data or it can be physiological data. Physiological data is how the patient responds to our treatment. A common type of physiological data in the pre-hospital setting is ETCO2, used to guide the ventilation process. Performance is our treatment to the patient, and this could be, for example, ventilation rate or compression depth. The last step in defining real-time feedback is how is data itself. It can be either objective, subjective, or it can be a combination. Objective is when our data is a measurement of our performance, which is actually, that's a fact. It's indiscussable whether my compression depth is correct or not, because it's objective data. Of course, there is equipment limitations or equipment failure, but other than that, the data is objective. Subjective data is when feedback is given by a colleague, and it is his assessment of my chest compression performance. If he assesses that to be too shallow, too deep, he'll guide me with his subjective opinion. And finally, the two can be combined. Physiological data is only objective, and we only measure the patient response to our treatment, and that is subjective data. All right, so moving on to some of the challenges we face in manual ventilation in EMS. Because not that many papers have investigated the challenges faced by ambulance technicians and paramedics when they perform manual ventilation with a BVM. Papers investigating have concluded that we tend to hyperventilate patients, and it may be harmful, but the reason that actually leads to this performance is largely uninvestigated. The few papers have mentioned some of the factors that may contribute to the challenge of performing correct ventilations. When we look at EMS, we often work in an uncontrolled environment where our focus may be challenged by having to pay attention to our surroundings and our own safety, which may lead to less focus on ventilation. And those of you working in a pre-hospital environment can probably appreciate some of the pictures here. Working in a dense crowd is definitely a challenge. Not that there's no challenge in hospital, but we are facing some of the challenges that are not existing at the in-hospital environment. The limited resources in combination with advanced procedures and the need to actually perform these tasks simultaneously is also a challenge, and it also contributes to the lack of guideline adherent manual ventilation. Sometimes we simply don't have enough high competencies on scene, which leads to us having to put the lesser experienced paramedic to just squeeze the bag, because we regard that as a simple procedure, and we have to use the advanced competencies to do more advanced tasks. And finally, despite several years of pre-hospital experience, a paramedic may simply not be exposed to the number of patients requiring manual ventilation for him or her to actually gain experience in doing so. At Kopenhagen EMS, we handle around 120,000 calls each year, and only 1% of those is cardiac arrest. An Australian study found that the median exposure to out-of-hospital cardiac arrest for a paramedic was 2 events per year. So this actually argues for a lack of routine despite having several years of EMS experience. All these factors are the reason why we should consider real-time feedback as the tool that may improve our practice. So to face these challenges, Kopenhagen EMS and Sol conducted a simulation study to investigate the use of real-time ventilation feedback. We recognize that out-of-hospital cardiac arrest is a worldwide health problem, and it affects close to 700,000 people in the United States and Europe each year. Fewer than 15% of those treated by EMS survive to hospital discharge. We know that cardiopulmonary resuscitation is essential to survival from out-of-hospital cardiac arrest. In addition to those high-quality chest compressions, ventilations must be delivered to the patient at an appropriate rate and volume to optimize the flow of oxygenated blood to the heart and to other vital organs to avoid impairing intrathoracic pressure. Myocardial perfusion, cardiac output, and blood flow to the brain have all been shown to decline with hyperventilation, while cerebral and coronary perfusion pressure significantly increases when ventilation rates are reduced. This study investigated whether real-time visual ventilation feedback improved manual ventilation quality during a resuscitation attempt in a simulated cardiac arrest scenario, and we used a novel flow sensor technology to measure the ventilations. We hypothesized that the use of real-time feedback during the out-of-hospital cardiac arrest in a simulated setting would improve ventilation quality. So, we did conduct a non-blinded randomized simulation trial enrolling 64 on-duty paramedics within Copenhagen EMS. Participants were allocated one-to-one to either real-time ventilation feedback or no ventilation feedback. We had 32 participants in each arm. They all received a standardized introduction, and then they conducted an 8-minute simulated out-of-hospital cardiac arrest, and they shifted between ventilations and chest compressions every 2 minutes. Manual ventilation quality was measured using a solid X series defibrillator equipped with a differential pressure sensor called the AccuVent, and it was attached between the back and the ET tube, as seen on the picture to the left. The ventilation feedback dashboard featured a breath-by-breath numerical value for ventilation rate, that's seen to the right on the screen. And it's to the left is seen the tidal volume delivered for each breath. In the middle, a countdown timer and a ventilation quality indicator, which is shown in or illustrated as a circle with a number in the middle. Numerics for ventilations delivered within a specified target range were displayed in green, while ventilations or parameters outside the target range were displayed in yellow. So as the ventilation was delivered, the countdown timer inside the ventilation quality indicator in the middle counts down to prompt the user to deliver one breath, and it was based on the target settings. When that breath was delivered, the circle, the quality indicator in the middle, gradually filled, and the target until the target volume was reached, and then the graphic would turn green if both numerics for tidal volume and for rate was within the set target, and it would turn yellow if one or both was out of target. So, the interesting part, the results from our simulation trial. The ERC guidelines for ventilation on an intubated patient recommends a rate of 10 breaths per minute. We found that compliance with guideline recommendations for ventilation reached 66.7% for the control group, and the intervention group reached a compliance of 97.4%. Besides the proportions, it's also worth noticing the dispersion of data for the control group and the intervention group, which is actually a very good indicator of not only the actual percentage, but also how good we are at delivering ventilations within target for that one patient. Moving on to tidal volume, the guideline recommends a tidal volume of 500 to 600 mils for each ventilation. We found that compliance with guideline recommendations for tidal volume reached 53.4% for the control group and 77.5% for the intervention group. And again, please note the dispersion of data. When combining correct tidal volume and correct rate delivered simultaneously, we found that correct performed ventilations for the control group was 22.1%, and for the intervention group we reached 75.3%. That is correct rate and volume delivered in one breath. And again, please note the spread of data for this outcome as well. Finally, we also controlled for participant covariates. We used age, hand size, EMS experience, training level, and cardiac arrest exposure as covariates. And we found that adherence to guidelines was up to 45.2%, higher in participants receiving ventilation feedback. So we concluded that real-time ventilation feedback increased guideline compliance with both ventilation rate and tidal volume in the simulated out-of-hospital cardiac arrest setting, and real-time feedback has the potential to improve manual ventilation quality and may also allow providers to avoid harmful ventilation during out-of-hospital cardiac arrest. So, looking at real-time feedback, the technology was first introduced nearly 20 years ago. However, it remains sparsely investigated. Since 2010, not more than 5 to 8 studies have investigated the use of that technology, so the potential is yet to be fully discovered. There's also a great potential for further development of the technology. At the moment, we use performance feedback as the main source of our data. However, we must also recognize that doing CPR is a one-size-fits-all approach. So if we are capable of delivering real-time physiological feedback for providers in the pre-hospital setting, I believe we could be facing another significant jump in survival. Despite the potential for real-time feedback, we must not forget the limitations, because we always teach our paramedics to treat the patient and not treat the monitor. So now we have to unlearn that mantra and actually try and teach paramedics to look at the monitor and not the patient while doing either chest compressions or ventilations. At the same time, we must also teach paramedics to navigate in treating the patient, treating the monitor, because they need to know the limitations of the technology, so they don't just blind follow what's shown on the screen. So we have to navigate and teach our paramedics to navigate in the best possible use of this technology, when to use it and when to trust their clinical judgment. This concludes my presentation. Again, I apologize for not being able to take any questions now.